Okay, I will start to talk to you because I think it's so time consuming and the break will be soon. So I try to do it in a shorter way than I wanted to do. So I will talk about the collective trauma and chronic pain in the present pandemic, a challenge in mental health professions. Can you hear me? Uh-huh. We are dealing with an unprecedented virus pandemic across the globe. The COVID-19 pandemic has created fear, isolation, illness, death, and long COVID diseases like lack of oxygen, fatigue syndrome, headache, permanent exhaustion, and others. It has changed the physical contact among people in a way never seen before. Since the beginning of this new pandemic, humans globally are involved in a time of uncertainty in the presence and in our future by mental illnesses on one hand as a result of isolation, and on the other hand as a result of social and physical distancing by law in an increasing way. In the western part of Europe, humans do not shake hands or hug people anymore, or they are hesitating to do. All these include, in particular, generalized anxiety disorders, pain disorders, psychological dissociation, obsessive compulsive disorders, and others. How can we understand a collective trauma? Okay, thank you. Now it works. Maybe you can make it bigger and go to the slide number 3. Next slide. No, this is too much. Oh yeah, that works. Yeah, that works. How can we understand a collective trauma? A wound caused by the fact that a group experiences unbearable existential stress and reacts with phenomena of division between submission and oppression. The violent exercise of power by certain governments or a fear-driven isolation amplify these stressors. Reasons for a collective trauma are war events, pandemics, Holodomor, genocide, ethnic cleansing, and also takeovers of power by despots or destructive sects, and etc. Next one, please. Oh no! Can you go to the further one back, please? In the absence, no, one more. No, next one. No, that one that was already a collective trauma. Yes. In the absence of attachment and relationship with others as preventive factors, trauma is exacerbated. For people who are particularly looking for truth and security, some of them fall victim to conspiracy theories, which divide in the corona pandemic society into vaccine opponents and proponents. Next one, please. Next one. Thank you. The corona pandemic has divided our society. In the left picture, so this should be like a scratch in the middle of this. These are two pictures. So if you look to the left picture of this whole picture, vaccination advocates demonstrate for health and economic security. And in the right picture, opponents of vaccinations gather and demonstrate for the right to self-determination about one's own health. Some find the health regulations and changes in the law to be important and correct. Others think that it is manipulative and grossly exaggerated. The forces of opposing mindsets go so deep that good friendships and relationships are breaking apart. Next one, please. So the consequences of the pandemic are fear of death, to get so seriously ill with COVID and to die lonely in a hospital without saying goodbye to relatives. Many children are afraid of infecting a loved one, of killing their grandma or grandpa by COVID. And fear of the disease, getting seriously ill with COVID yourself, or fear of the consequences of not recovering from COVID infection. So we deal with long COVID. I'm sure you heard about it. Next one, please. But if we as social beings are forced to keep physical distance, we can no longer comfort one another, cannot give support and security. Very old people were particularly involved, were not allowed to meet their grandchildren for many months. They were becoming isolated, disoriented, and lost touch and closeness with their beloved relatives. The consequences are significantly higher score of major depression, Alzheimer's disease, and chronic pain. And physical contact is minimized. Next one. Virtual home office schools lessons have replaced lively class lessons. Parents inevitably became assistant teachers. Schools remained closed. Parents had to go back to work and at the same time look after their children at home. Several lockdowns with isolation and social distancing were leaving lasting traces on children and adolescents that research shows up more and more. So we never had, next one please, we never had in this century a full generation in school and university that lost a lot of knowledge and so on. So here you see statistics of the prevalence of chronic pain from Harald Breivik from Norway in 2006. So this is an older one. It was the most comprehensive study in Europe about chronic pain. The range is from 12% on the left side in Spain to 30% in Norway. Germany is in the middle with 17% of chronic pain diseases. You see that it differs from country to country, and so it is globally also that this statistics is seen better in national statistics. Next one, please. Go to the next one. Next one, please. Next one. Next one. Oh, there's something else. Next one. Okay. No, I think we have not this picture here. Is that possible? It's chronic. Okay, chronic pain and age. If we look at chronic pain and age, we see that young people suffer the most under acute pain and the less under chronic pain diseases. That looks interesting. You see the green bar is acute pain and the red bar is chronic pain. So in aged people on the right side, over 75 years, have the most chronic pain and few acute pain. What does it show? Young people are connected with family and children and living in social groups. So they have not this chronic pain situation. Aged people, on the other hand, are more isolated from communities. They are living frequently alone, lose their loving partners, and these are prominent factors and causes for chronic pain. Now maybe you can go back to some slides. One, go back. One back. Okay. Yeah, that's fine, this one. I tried to find it. Now I want to pay your attention of the factors of chronic pain nowadays. Factors of chronic pain. The basic understanding in medical care of chronic pain has remained largely the same, despite many pain studies over the last 20 years, as it was 100 years ago since René Descartes. To be precise, current pain studies deal with the psychological and social relationships regarding to chronic pain. Psychosocial areas affect 66% of all factors in chronification. So the social and the psychological factors are the most important as a cause for chronic pain. So now in medicine, we have more the bottom up, starting with the cells and with neuroscience, and as a cause that something in the body and in the brain function is damaged, but the causes are not in the symptoms. The causes has to do with these factors I am talking about. Can you go to the next one, please? So no, again, back to the other one, sorry. So we have the nociceptive pain is the biological pain, neuropathic pain. And we have, this is combined with the psychological that have depression. That is something I would say a following factor when people have for longer time chronic pain. Distress, catastrophization. This is the emotional part. And the third one is the social pain behavior. So how you behave when you have chronic pain. So can you go to the next one? Yes. If we see the epidemiology of chronic pain in the present by the German researcher Zenz and others in 2017, with a large sample of more than 10,000 chronic pain patients in clinics, we can see that 40% have back pain. This is the blue, the big one, and 23% of the sample have neuropathic pain. So we would not expect that neuropathic pain is so high scored in this. And 21 have muscle, joint, and bone pain, and 12% have headache pain. So we would see more of people, researchers also think that headache is number 2, but it is not number 2. Number 2 is the neuropathic pain. So this data differs also in countries. This is the German study. Can you go to the next one, please? Next one. So I will talk now about the biopsychosocial paradigm of George Engel. Since 1977, it was published in the American Journal of Psychiatry, 1980. And you see this is a top-down graphic. So from top, you have in white, you have the biosphere and culture. That is also important in trauma that we are talking about today. And the green that is important, that is the social, that there are communities, family, couples. And the red window is the psychological part of a person with his experiences and his behavior. And the blue inside is the biological component from the nervous system to the cells and molecules and so on. Can you go to the next, please? So the social context is stronger and more powerful because it is more complex than the biological, and it contains the causes for chronic pain. That's what we know today. For instance, influences are of being exposed as a weakling, being neglected, or seen by pain experts as a simulant is a crucial factor. Or being laughed at in social groups, that we also see this in now this online social communities like Facebook and TikTok and all this. People can get a lot mobbed or by bullying by others. So, and also personally unprocessed fate underlies many states of pain. Okay, go to the next one, please. Next one. So what happens in the brain? We have circuits of brain signals in the brain of chronic pain. We receive acute pain. You see this yellow arrow. We receive acute pain from our body by nociceptive fibers from the skin via the spinal thalamic nerve pathways to the thalamus. Next one. From there, pain signals are processed in the somatosensory cortex field. This is the blue one. It is the brain area where we sense pain, called the somatosensory functional circuit. The brain area where we feel emotionally pain is in our limbic system, called the affective emotional function circuit in red. You see the red part of it. Finally, the pain signals reach the frontal lobe where we recognize pain, called the cognitive functional circuit. You see in the yellow. The yellow and red area are very important for pain regulation. For instance, positive thoughts, confidence, and motivated feelings. Therefore, pain-relieving chemicals were released in the brainstem, which inhibit pain in the body. Patients having, you see this in the brainstem area. Patients having chronic pain are suffering from constant pain without hope or end of pain. Anxiety and depression are seen as consequences of chronic pain. When a pain doesn't go away, one becomes despondent and helpless. For instance, I will never be able to windsurf again. Clients having these feelings and thoughts, pain inhibiting chemicals were not released and the pain cannot be interrupted. Next one, please. Next one. In chronic pain, our director is the brain. Chronic pain states always have a close, go back to the last one. Last one? Yes. Chronic pain states always have a close interaction between pain perception and the unconscious and conscious mind. So this interaction between pain perception and unconscious and conscious mind is important. If we treat our patients with special techniques of pain psychotherapy, we have access to the limbic system of the brain with emotions and the frontal lobe with our cognitions. And we can treat many people more effective and with sustainability. So we will talk about this later. Next one, please. So let me talk about the treatment techniques, including pain anamnesis. So the pain anamnesis in the psychosocial model. It contains, so we are asking, what experience of pain did you have in your life? So it is not separated if it is a physical pain or is it an emotional or social pain. Pain is pain. So we do not make these differences. We call it the history of pain. This is, next one please. This is a drawing of an 11-year-old boy with inexplicable pain. You see written in this picture, why I am sad, because my dad punches my mom in the face. And that's why I'm sad. So when I was treating this boy, so we had the setting to work with this boy about his experiences, and also with the parents parallel. And we saw, so we couldn't interrupt the stress that was in the couple by the man to the woman. And at the same time, when this young old boy could also express his feelings about also his stress and terror he was receiving. So in a few sessions, the pain was gone. So you can see that this trauma history and pain history, the equivalence of it. Next one, please. So what we are using is a special felt sense technique. In pain therapy, we locate the emotional processes by a felt sense a part in the body. For instance, we can ask, so I feel very hopeless, and we are asking a patient, where do you feel the hopelessness in your body? And you will hardly believe that it always works when you are connected in a limbic way to your clients and not in a cognitive way by talking to them. So this I developed for the treatment of chronic pain. Next one, please. So we will see a little bit to see inside of this technique. So we see the pain as an issue. So we are asking, how does the sensation of pain affect you? Find a place in the body, so we call it felt sense, with the feelings that arise. For example, feel at the mercy of. Then when the patient is saying that, therapist can say, where do you feel at the mercy of in your body? And the client, here in the middle of my breast. And therapist says, now let come up whatever comes up. So we address it to the unconscious mind of a client. Memories or physical sensations or emotional feelings or inner images can arise, let arise whatever comes up. So that's what we ask. And so we open the door that anything can come up, and we let the client consciously controlled breathing. This is important because a controlled, slow breathing, calm and slow breathing enhances the parasympathetic system. So the vagus that is also manipulating the sympathetic system. So the sympathetic system is decreasing when you start this controlled breathing. So the end of session is about find an eye focus to train at home. What does mean an eye focus? An eye focus means that if we gaze, so if we think about something or we are concentrate, we have like eye positions looking in the nowhere, looking into that we gaze. And this gazing we can also use therapeutically to work with. So I cannot talk too much about this, but this is also part of this technique. Next, please. So this is about chronic joint pain. You have seen that the chronic joint pain is number 3 in the statistics. So it is very, very prominent to have healing techniques for and also the sustainability for treating a chronic pain, joint pain. So because of what? Because osteoarthritis doesn't have to hurt. This is not what we have heard also in the medical science the decades before. But what exactly does that mean? Pain does not come directly from the wear or tear of the cartilage. The cartilage has no pain receptors. This is why there are also numerous elderly patients who have no symptoms and in whom osteoarthritis was discovered by chance. So you can see that this is very interesting, that when someone has problem or chronic pain in the knees, that does not mean because they're elder and they have, the cartilage is damaged and so on, or the osteoarthritis is enlarged. It has not to do with these things, as we can see. It has to do also with the factors around them. So we will go to there soon. Go to the next, please. Next, please. Next slide. Yes. This is about the fibromyalgia syndrome. I'm sure that you heard about this. This is a clinical complex of symptoms in which pain in different parts of the body is alternatively in the foreground. No causal explanatory structural damage or biochemical deviations detectable. Neither rheumatological rheumatological or nor orthopedic nor neurological. The problem to this day is that in the absence of diagnosis, these patients are viewed as simulators or as imaginary patients, like Molière said, la malade imaginaire. Porges, Stephen Porges, an American neuroscientist, thinks that fibromyalgia is probably associated with the disruptions of the subdiaphragmatic vagus regulation. In particular, regular manual pressure techniques that I developed is proving to be temporarily effective. I will show now next picture, a case study I brought to you with also 2 videos at the end. I hope it will work. This is about the CRPS, complex regional pain syndrome. The older meaning is Sudeck disease. So this is about a 59-year-old woman that her mother died during childbirth. And the mother, before she died, she said her husband that she was not the child, that the girl, my patient is not the child, that he was not the child father, and which turned out to be wrong 20 years later. So she discovered that it was not true. So whatever that means, that a mother giving birth is saying these things. So this is also about traumatic issues. A few years ago, it turned out that her husband, so she was now with family, had a husband, and a few years ago, her husband has had a parallel relationship for 8 years, which follows with separation, divorce of the patient. Then from that on, she lived alone since then. And after a fall with a broken forearm 3 months ago, before she went to therapy, followed by a cast, chronic pain with hypersensitivity to pain occurred. This is also called hyperalgesia. So the diagnosis was the CRPS syndrome. And in the pain-focused treatment I did, included also pain history that you heard, breathing technique and grounding while describing the traumatic experiences of isolation after the birth that came up to her in the first session. And end of the 90-minute session with a body resource scan developed focus with 8 breathings techniques for 3 minutes each. So 8 times a day, she made for 3 minutes these breathing techniques. And she felt more mobility and almost no pain in her left hand immediately after the treatment. Then you see the next pictures. So watch the right picture with this, it is her left hand with this, yes, after a week. The client said that she could already raise up a full glass of water with her hand, and the pain intensity has since improved with fluctuations. So you see the difference between 1 week. If you go, maybe you switch forward and back, because when we started, last picture, and so you see the form of the hand, so glossy, and very painful, like hyperalgesia. And go to the next one. Go to the next one. After 2 weeks, you can see that the swelling has decreased, and also the pain sensation. So also the pain sensation decreased from session to session. And after 10 weeks, now we have 2 videos. Maybe you can start the first video after 10 weeks. I hope it works this time, because it is very impressive to see how fast this chronic pain, Sudeck pain, CRPS pain.
Das ist super. Das ist so wie umrühren. Nächste Woche mache ich Kekse.
Du machst jetzt Kekse, genau.
Ja, das Rollen ist sicher auch gut. Ne? So. Ja.
To get you can prepare the next video, please, meanwhile. And she prepared, she was asking about music, and I played some music that she liked by my devices. And then she moved with that, and you see also emotionally what changed in this therapy. And the end was after 17 weeks. So 17 weeks, it's about nearly 4 months, between 3 and 4 months.
Okay.
Ja. Wow, jetzt drehst du es aber noch mehr.
Ja, schau.
Wow!
Jetzt spürst zwar ein bisschen oben in der Schulter, aber das ist wurscht.
Du atmen gleich?
Ja.
Atmen.
Okay.
Ja, sehr gut atmen.
Schau, das geht jetzt auch schon schneller mit den Fingern, siehst du das?
Ach so,
Viel
ja.
schneller.
Und mach mal Daumen.
Daumen? Was mit Daumen?
Ja, einfach Daumen bewegen, ja. Das hast du nämlich am Anfang.
Habe ich auch nicht können, schau.
Ja, toll.
Schön.